For those of you who are joining us right now, my name is Emma. I am a fourth-year medical student working with Motivate MD. I am excited to say I'm graduating soon, yes, going into emergency medicine. And we're going to talk about a really cool topic tonight that I think is a little bit lesser known. Correct me if I'm wrong. And hopefully you guys get a lot out of this. I hope this is exciting for you as you begin your journey to medicine yourselves. All right, here we go. I love comics. I think you guys will probably see that throughout the presentation, but hopefully you guys have the Google document up on your screen along with this presentation. Link is in the chat now. If you don't have that, that is the link to the SOAP note, which is a document you'll be filling out throughout the presentation if you wish. And there is also a quiz at the end pertaining to this presentation where you guys can test your knowledge and see how comfortable you feel with this material. Anybody not have that information? Anybody needing the link? All right. Like I said, I couldn't resist. I don't know if you guys have ever been to a concert where immediately afterwards or even the morning after, you just cannot hear anything. I could totally relate to this, so I thought it was kind of funny. Okay, session outline. So today we will be going through a case together, case being regarding a specific patient, their symptoms, etc. And while we're going through this, I want you guys, like I said before, to fill out your SOAP note documentation. For those of you who don't know what a SOAP note is, the SOAP note is essentially the standardized way that physicians organize their medical record when they meet with a patient, how they organize their documentation of the patient's visits. So S stands for subjective, and the subjective is essentially everything that the patient tells you. Why are they here? What symptoms do they have? Do they have pain? Have they taken anything for their pain? What makes it better or worse? Does their pain radiate? Things like that. So as we go through the case, try to keep note of those little details, because as you guys will come to find when you begin medical school and your journey as physicians, those little details become everything. So that is the subjective. The objective portion of the SOAP note pertains to all the things that you find objectively during your physical exam, which, as you guys can see on the screen, is something we'll go through in depth together. We will then go through the differential diagnosis, which essentially means it's a list of what you think the patient has in terms of most likely to least likely. And we'll go through each of those and determine why one is more, makes more sense than the other. In terms of the assessment and plan, so the assessment is essentially the differential diagnosis, and the plan is exactly what it sounds like. It's what you want to do for this patient. Do you want them to have labs? Do you want them to follow up with you in clinic in 2 weeks, etc.? And then we'll go through a brief lesson on the pathology of our disease, compartment syndrome itself. So, like I said before, I want you guys to feel welcome to actively participate. This session is for you. It's to get your feet wet with medicine, start to figure out what you're interested in if you like these kind of emergent topics. And then throughout the presentation, please feel free to interrupt me if you have any questions at all. I want this to be fun and have you guys feel like you're a part of it too. So any questions at all before we get started? No questions. All right, keep going. Okay, here's the SOAP note that you guys should have from that link in the chat. So here's our case. A 28-year-old female presents to the emergency department with a chief complaint of right lower leg pain. Patient states that about 2 hours ago, she was in her yard cutting down trees when a large branch suddenly fell onto her right lower leg, briefly pinning her to the ground. After the branch was removed, she noted immediate sharp pain, redness of the skin, and tenderness to touch. Since the incident, she has developed worsening sharp pain and decreased sensation to touch. She is not able to bear weight on the leg and has minimal ability to move her right toes and ankle. She has tried icing and ibuprofen for the pain, but says nothing is making it better. She says her leg is feeling tight and the pain has become unbearable. She is worried that she broke a bone and would like to get imaging. So, with just this very brief patient history, what sticks out to you guys about this case so far? Any symptoms that she mentions in particular that you guys are thinking about? Okay, I'm looking at the chat. I see loss of sensation. Absolutely. I see minimal ability to move the toes and ankle. Yeah, those are key findings. Absolutely. Does anybody else have any thoughts about what we've learned so far? Meds aren't working. Yep, leg feels tight, can't bear weight, unbearable pain, complaints of severe pain. Yeah, absolutely. Those are all key things, really great things to be pulling out of her HPI right away. So awesome job. Okay, so before we get into all the medical jargon, I wanted you guys to have something to reference throughout the presentation when I'm just kind of spewing this stuff at you or you're seeing it on the screen. So go ahead and take a screenshot of what you see of this slide so you can reference it throughout the presentation. A lot of medical jargon, as you guys I'm sure have already come to find. So I'll give you guys a couple more seconds here to take a screenshot and then just have that pulled up on your screen while we go through the case. Okay, I'm gonna keep going. All right, so let's dive into the physical exam. We're gonna start with vital signs. Vital signs are extremely important no matter what specialty you guys go into. One of the first things you're gonna talk about with your colleagues when you're presenting a case are the vital signs. So let's take a look here. We have a heart rate of 100, respiratory rate of 19, blood pressure 160/80, temperature 98.5, and SpO2 100%. So looking at these vital signs, do any of these seem abnormal to you guys? See, blood pressure is a little high. I definitely agree with that. Blood pressure is weird. Blood pressure, heart rate and blood pressure. Nice, Catherine. Yes, heart rate, Stephanie, good. Yes, I totally agree with you. So we're going to start with heart rate. So heart rate of 100, that's a little high. We would consider that tachycardia. Heart's going a little faster than we would like. And we want to kind of think about the reasoning for that. So in terms of why do you guys think her heart rate might be high? What possibilities do you think there are for her being tachycardic? She's in pain. Yes, very good. Trying to pump harder because of the blockage. Okay. Anxious and stressed. Yes, absolutely. So all of those things are absolutely things you want to think about when a patient comes in and you're looking at their vital signs in the emergency department. So certainly pain can cause your blood pressure to elevate. And for a 28-year-old female, that's a little high. We would expect a blood pressure like that perhaps in older patients, like 40s, 50s, to be a little bit more normal. However, for her being so young, that's a little high. And I agree with you. I think there is some other factor going on, potentially pain, potentially feeling anxious. Being in the emergency department is a very stressful experience. There's so much stuff going on all at once. People are running around, there are all these noises. So white coat syndrome, if you guys have heard of that before, is absolutely a real thing. And she might be experiencing that right now. Good. All right. How about respiratory rate? What do you guys think about that? Fast. Yep. Good. Anybody else have any thoughts about that? Anybody know where our threshold is for breathing too fast. 12 to 16 normal. Okay. So typically less than 20 is kind of what we would consider to be normal. So 20, 21 and above is when we start thinking, okay, why is this patient hyperventilating? What's going on here? They're breathing a little bit faster than we would expect. Any thoughts about why the patient might be breathing faster than normal? Because of pain? Agreed. Yes, I like that. I think that's totally reasonable thought. It could also be because of trying to pump blood to a desired area. Okay, maybe the doctor was observing and she became aware. That's a good thought too. Yeah, definitely something to keep in mind for sure. So respiratory rate being kind of at the threshold of what we would consider to be normal. We'll keep an eye on it. We'll keep an eye on it. It's a little faster than we would like, but potentially because of pain, potentially because she's in a stressful environment, or related to the pathology that she has going on that we have yet to discover. All right, blood pressure, 160 over 80. So can anybody tell me roughly, no worries, Stephanie. Can anybody tell me what's normal in terms of blood pressure about? I know the guidelines tend to change fairly often. 140 over 90, okay. It's a little high. 140 over 90 is a little high. 120 over 60, I see 120 over 90, 120, I think you mean over 80. Yeah. So I would say patients want to shoot for, or pretty much everybody wants to shoot for a systolic, which is the top number, blood pressure of 125 and below. And obviously you guys, I'm sure, are aware that your blood pressure changes throughout the day depending on what you're doing. Are you working out? Are you feeling stressed out? Are you relaxed? Are you doing a yoga class and you're in Shavasana, which is my favorite position when you're laying flat, kind of taking a nap? That will definitely change your blood pressure. So those are certainly considerations for her as being 160, which is definitely higher than what we would expect over 80, which is also a little bit high, but not too bad. Diastolic is not too bad. So definitely things to keep in mind. How about temperature? Is 98.5 degrees Fahrenheit? Does that seem like it's in the normal range? Normal. Yep, I see normal. I'm seeing some head nods. Yep, good. Absolutely. You guys are right on the money here. Sorry for those of you in Canada, we're using Fahrenheit here. We're still not quite caught up to you guys yet. Yes, agree. 98.5 is just fine. How about SpO2? What is that measuring exactly? Oxygen level in the blood. Harley, yes. Nailed it. Exactly. Oxygen saturation, oxygen levels. Very good. You guys are way too smart. That's exactly right. What do we think about 100%? Is 100% normal for somebody her age? Very good. Great. Yes. I agree with all of you guys. Yeah, it's excellent. For somebody her age, we would expect it to be that high, especially if she's breathing fast like that. Very good. Excellent work. All right, let's move on. So we're going to go to general now. So the general part of the physical exam is pretty much what it sounds like. It's how does the patient look to you? Are they in distress? Are they like writhing around in their bed? Do they seem like they're in unbearable pain? Do they seem like their stated age? That kind of thing. Do they appear somnolent or aka sleepy or arousable? So that's what general refers to. And for our patient, she appears uncomfortable and in moderate distress. And that makes sense given the story that she told us too, with a branch falling on her leg. That sounds terrible. So that fits. Let's move on to HEENT. Anybody know what that stands for?
It's head, ears, eyes, nose, and throat.
Yes, very good. Excellent work. It's exactly what it stands for. And I'm seeing the same thing in the chat. Really good. So basically, neck up. That's what that section is assessing. So for our patient, her head is atraumatic. That's a good sign. Branch didn't fall on her head. We don't see any signs of blood. We don't see any signs of like leakage of any kind of fluids or otherwise. Head is normocephalic. What does that mean? Normal, I see in the chat, normal. Normal shape and size, yes, very good, exactly. Normal shape and size, yep. So her head checks off the list. All right, moving on. No tenderness to palpation of the neck. Normal range of motion, ROM is range of motion of the neck. Those are all good signs. So whenever you have a patient who has had some kind of trauma, be it a car accident or a branch falling on them, it's very important to kind of assess their entire body. Sometimes when patients have gone through something stressful, they might miss telling you things. They might not have realized something else happened during the trauma when the branch fell. So it's important to assess important structures such as the neck. As you guys can imagine, the neck has a lot of important anatomy, vasculature, it has your windpipe, your esophagus. So we got to make sure that that is okay. And for our patient, she's got normal range of motion, which is good. She can turn her head just fine. She can flex and extend her neck. Those are all great signs. So we're not worried about any kind of fracture of her neck at this point. Good. How about PERRL or PERL? And EOM, what do those mean?
PERRL stands for pupils equal, round, and reactive to light.
Excellent, very good. Nailed it. EOM, extraocular muscles. Yes, I would totally accept extraocular muscles or extraocular movement too. Yes, very good. So pupils are equal, round, and reactive to light, and extraocular movements are intact bilaterally. Those are very good. Anybody know why it's important to assess essentially the size of your pupils? So you take a pen light, you shine a flashlight, and you look to see if your pupils change size at the same rate. Does anyone know why that's important? She could have a brain injury. Yep. Nervous system check, nervous system's intact, brain damage. Yes, exactly. All of those things. So like I said before, in a patient who has experienced a trauma, it's very important that you do a thorough exam. Yes, Catherine says cranial nerve damage. Absolutely. It's exactly what we're looking for. Good. And then to check extraocular movement, I bet you guys have been to a physician, or if you wear glasses and you have a patient testing your eye muscles, they kind of do that H formation. That's testing your extraocular movements. And then accommodation is when they put their finger kind of close to your nose and make you go cross-eyed. And that's another important part of the extraocular muscle assessment too. Very good. All right, let's move on to lungs. What does CTAB stand for? I do not expect you guys to know. Oh my gosh, but you do. Cleared auscultation bilaterally. Yeah, nailed it. So that's shorthand script that's often used in physician notes. So cleared auscultation bilaterally. Very good. We don't hear any wheezing. We don't hear any rhonchi, meaning like fluid in the lungs to make it sound kind of like crackly almost, or rails, which is similar. So that's what that means. And no increased work of breathing. So thinking about increased work of breathing, that kind of relates to her respiratory rate, which was 19, which is just below the threshold of breathing a little bit too fast. So it's a good thing. She's probably just stressed out, but we'll see. We'll keep checking everything over and make sure she's okay as we go through the rest of our exam. All right, let's move on to CV or cardiovascular. We have tachycardic. That makes sense. We found that through when the nurse collected vital signs. Radial pulses are intact bilaterally. Can anybody tell me where the radial pulses are? Lateral wrist, wrist, forearm. Yeah. Very good, you guys. Yep. So radial pulses are right here. Sometime before a test, you know, I would check those and see like how nervous I was, how I was physically giving away how nervous I was. Yeah, same here. Yeah, that makes me feel better. But yeah, radial pulses are frequently checked. You know, when you guys go to the doctor, they're trying to get a pulse if they don't have the fancy equipment to collect that information. The nurse will look at her watch, time it, and count the number of heartbeats, either 30 seconds or 15, do a little math, etc. So it's good that we can hear both of her radial pulses. That's a good sign that her upper body vasculature is intact. There's been no damage to her upper body, which is also an important factor to think about when you're assessing a trauma patient. All right, next we have capillary refill is less than 2 seconds in the bilateral upper extremities. That's what UE stands for, upper extremities, so your arms. Can anybody tell me what capillary refill means? Push the nail and see how long it takes to go pink again. Yeah, exactly. Yep, that's exactly what it is. So capillary refill is a quick test to check vasculature. Very good. All right, next we have pedal pulses are difficult to palpate in the right lower extremity. Okay, so let's back up a second. Can anybody tell me what the pedal pulses are or give me an example of a pedal pulse? It's okay if you don't know. The pulse in your foot, I would agree with you. Pulse behind the ball of the foot. By ball, what do you mean? Malleolus, yeah, very good, exactly. Excellent work. So there are a few places, dorsalis pedis, gosh, you guys are smart. Dorsalis pedis is exactly a perfect example. So there are a couple of places where you can check a patient's pulses in their feet, essentially, or by their ankle. One is dorsalis pedis, which is kind of on top of your foot. Honestly, throughout my medical school and experience and clinical clerkships, my 3rd and 4th year, I had trouble finding pedal pulses sometimes because they're not always where you would think they would be. However, behind the medial malleolus, which is the medial aspect of your ankle, that one is usually pretty easy to palpate. That's a good one to check if you can't find the dorsalis pedis, which is, like I said, usually on top of the foot. So hers are difficult to palpate in the right lower extremity, so that gives us a clue about something. What does that give us a clue about? Low blood flow, perfusion is poor, decreased blood flow, lack of blood flow in the legs, poor blood flow. Yep, I agree with you. Something is making her peripheral perfusion or her blood flow in her lower extremities kind of wonky in her right lower extremity. So that's something that we should keep in mind. That's an important finding. All right, let's move on to neuro. So we have cranial nerves 2 through 12 are intact. Can anybody tell me why it's important to check the cranial nerves and what are the cranial nerves? It's kind of a hard question, so I don't expect you guys to know it. Nerve supplying the head, eyes, face, etc. Yep. Innervate lots of structures, vagus nerve. Very good. Yeah, very good. So essentially, the cranial nerves are an important physical exam finding to assess for during whether or not a patient has been through a trauma, for example, and they may have injured a part of their body that they might not be aware of yet because of shock, things like that. Another example of when you would assess the cranial nerves would be a patient who has a stroke or who had a stroke. And that would be a patient who comes to the emergency department and says they have a facial droop. Doc, I just can't feel, I feel like I can't smile on the left side of my face. I feel like my left eyelid is drooping. That would be a good time to check the cranial nerves. That gives us a clue about which parts of the brain could be affected by the stroke. So at least for our patient, luckily, hers 2 through 12 are intact, so that's good. Sensation to light touch is diminished in the right lower extremity, distal or beyond the knee. Achilles reflex is 1 out of 4 in the right lower extremity. So what does this information tell us, do you think? Diminished sensation to light touch, you just can't feel it. It doesn't feel the same on both sides. The nerves are impinged somewhere. Yeah, I like what you're thinking. Numbness of the nerves, okay. Yep. Any other thoughts about Achilles reflex 2? The Achilles reflex is essentially your ankle reflex. Reflex isn't as strong as it should be. Yeah. So similarly to the cranial nerves, these reflexes tell us about the integrity of the nerves that cause our muscle, for example, to contract with our Achilles nerve reflex. When you take, honestly, nowadays, your cell phone, typically an iPhone, and you kind of tap the back of your Achilles tendon to see if the ankle responds. And what that assesses is the integrity of the nerve, the nerve's route from the motor neurons within the muscle itself to your spinal cord. There's a circuit there that you guys will spend a lot of time learning about. And it's very important to assess the function of those nerves because it tells us a lot about what kind of issues neurologically that a patient could be experiencing. And then the same is true for sensation to light touch. So if a patient, even who had a stroke, for example, says when you're assessing their sensation either in their upper extremities or their lower extremities on their feet, and you're just using light touch to gently essentially brush the skin on their legs, and you say, does this feel the same on both sides? And they say, oh, this feels a little bit different in my right calf. That gives you a clue about where the patient could be experiencing a neurologic issue. So another important finding that we have. All right, moving on to MSK or musculoskeletal. So skin overlying the right lower extremity appears edematous and tense with diffuse superficial abrasions. So medical jargon here. What does edematous mean? Swelling, swollen. Yes, something with swelling. Yep, very good. You guys are correct. Means that there's some swelling going on. How about tense? What does that make you guys think of? Hard to the touch? Yeah, I like that. Muscle is contracting. That's a really good thought. Stiff muscle. Yeah. So in terms of our physical exam, tense is referring to the actual skin. So the skin is tense or it looks really tight. It doesn't, move around as much as you would expect it to. It's just kind of hard and seems very stretched. And that is not a normal finding. That's not what we would expect. So something to think about. And then the diffuse superficial abrasions. What does abrasion mean? Cut. Yep. Scratches and cuts, exactly. So superficial meaning it really doesn't go deeply into the skin at all. It's more of a surface kind of scratch, probably from the branches of the part of the tree that fell on her leg. So severe and diffuse tenderness to palpation. Okay, that's an important finding. That is not normal. So we'll definitely have to keep that in mind. Pain is worse with passive and active flexion and extension of the right ankle. What do you guys think about that? Is that a normal finding? Her tendon sheaths are compressed. Pain is constant, not due to motion. She can't move. Yeah, those are all really good thoughts. So as you guys know, maybe even when you're sitting at a desk studying for an exam and you kind of stretch out your legs, you know, flex and extend, move your ankle back and forth, inwards, outwards, up and down. That should not hurt. That's a very important physical exam finding that pertains to our differential diagnosis when we're trying to narrow down what this patient has. So to figure out our differential diagnosis, we need to take all of her symptoms and we need to take her story and we need to look at her vital signs. And that's how we think about, what does this patient have? How can we put this in order of most likely to least likely? So with that, let's keep going. All right, so compartment syndrome. Before we get into more of the details of compartment syndrome, I wanted to give you guys a brief overview of the anatomy of the leg itself and explain what compartment syndrome is. So before I dive into those details, can any one of you brilliant students tell me what compartment syndrome is? Don't be shy about getting this wrong. I definitely could not get this right at your stage in the game. So, compression of structures in the limb due to swelling. Nailed it. Yep. Very good. Exactly. So that's what compartment syndrome is. So looking at the screen, looking at this particular slide and the anatomy of the leg, you guys could probably see that there are a lot of different muscles in your leg. And those muscle groups are separated by little compartments. And these compartments are separated by what's called fascia. And fascia is a connective tissue that tends to encompass different organs in your body. And that's important in compartment syndrome because fascia is not flexible. It does not expand and contract with, you know, the situations of life. And so certain parts of the body, such as the anterior compartment that you guys can see in kind of that yellow golden color on the screen, that is an area that is prone to developing compartment syndrome. And let's say you're in a car accident and that part of your leg gets squished by the car door or something like that. That causes damage, and that damages the muscle, and it leads to swelling of the muscle, which is a natural reaction to try to get your white blood cells in there to try to facilitate healing of the tissue. That leads to swelling, and the fascia doesn't like that. So when the muscle starts to swell, that leads to problems because, well, let me take a step back. Can you guys think of why that could cause problems? Swelling of the muscle itself. Think about the symptoms our patient had. Pinching of nerves and vessels, Rachel. Very good, exactly. That's exactly why this becomes a problem, is because the swelling leads to cutting off the vasculature, the blood flow to the muscle itself. And that is not good for the muscle. As you guys can probably imagine, the muscle will die and leads to excruciating pain, etc. Same thing is true for the nerves. The swelling of the muscle itself squeezes down on those nerves and leads to symptoms like trouble with motor movement or movement of the patient's lower extremity. And then also paresthesia, which is pins and needles sensation that patients can sometimes complain of with lots of different things, but compartment syndrome is one of them. So does anybody have any questions about this slide or the anatomy before we keep going? Okay. All right. Well, if anything comes up, go ahead and put it in the chat or feel free to interrupt me. Okay, let's get into our differential diagnosis / assessment. So number one, as you guys probably could have guessed by now, is acute compartment syndrome. So that correlates to the picture that's parallel with it, that crazy looking arm that's cut open. That is compartment syndrome. That is treating compartment syndrome, which we will talk about in detail. So I'm just gonna save more of the details of compartment syndrome for when we dive into the pathology. And we're going to go ahead and go to number 2 on our differential, which is deep venous thrombosis. Can anybody tell me what deep venous thrombosis means? A clot, yes. When a blood clot forms in the leg, clot in the deep veins, blood clot. Yes, very good, you guys. What kind of situations would you expect would put a patient at an increased risk for developing deep venous thrombosis or a DVT? Contraception pills. Wow, you guys are so smart. Yeah, a long flight. Very good. Exactly. Yes. So contraception pills or oral contraceptives, those estrogen pills and sometimes progesterone are mixed that women sometimes take for birth control do put patients at an increased risk of developing blood clots. Good. Okay. Long time without movement, sitting for a long time. Exactly. Yeah. So conditions where patients have to be seated, like a long flight, that's a great example, or a patient who just had surgery and is on bed rest. Those patients would need to be very conscientious of getting up and either walking if they're able to walk, or there are certain devices that patients can use. They're called sequential compression devices. And those are kind of like these little tubes that patients have put on their calves, and they inflate and deflate with air over time to kind of squish the calf muscles to keep that blood moving, because venous stasis or the lack of blood movement in the legs can lead to the development of a clot. Yes, very good. Does anybody know what would be a complication of a DVT? This is a bonus question. A PE, oh my gosh, yeah, exactly. A pulmonary embolism, very good, yes, excellent work. So patients who have a DVT can absolutely develop a pulmonary embolism, and that is when a clot within the venous system of your leg breaks off and travels into a patient's lung. And that can cause a whole host of problems. They could have symptoms like shortness of breath, chest pain, things like that. And sometimes, you know, the patient can survive a clot without necessarily getting medical treatment, but other times the clot can be so big that they need to be put on blood thinners and monitored very closely. I see Megan asks, could it also travel to the brain? That's a very good question, and the answer is yes. I don't know if you guys have ever heard of the foramen ovale or ever heard of the term patent foramen ovale, but the foramen ovale is essentially a hole in your heart that you have when you are a fetus, and it allows blood flow to essentially bypass the lungs, because when you're in utero, you don't need your lungs. You're getting all your oxygen from your mom. And so for some patients at birth, the foramen ovale doesn't close. And when that happens, that puts a patient at greater risk for having a clot, if they ever developed one, to skip between their atria, the two chambers within their heart above the ventricles, and that could lead to the clot traveling to their brain and causing a stroke. So that's a very good question. It closes when they take the first breath, right? Yes, so the foramen ovale should close soon after the baby is born, because there are a lot of different hormones and proteins within the baby's body. Prostaglandin is the main one that leads to assisting the foramen ovale with closing. And it's normal if it doesn't close all the way. Sometimes it can take a little bit of time, but the problem is when it doesn't close over a long period of time. Very good questions. Okay, just quickly looking at this picture here, I don't know if you guys can tell that this patient obviously has a DVT. That leg looks pretty red. It looks pretty red. It looks a little bit bigger than the other leg. And those are some key symptoms that a patient could have when they develop a DVT. And we want that on our differential diagnosis, because those symptoms kind of similar to what our patient has. So it's really important when you're considering how to treat a patient, you need to be able to rule out the other dangerous conditions that could kill a patient and essentially prove to yourself and to your team why this patient has acute compartment syndrome versus something like a DVT. All right, and then finally we have rhabdo. Does anybody know what rhabdo is? Rhabdomyolysis. Muscle protein breakdown. Good, yes. How does that happen? When would you get rhabdomyolysis? If you give a Z-Pak, someone on statins for cholesterol, wow. I don't actually know what Biaxin is. Is that like a brand name for an antibiotic, maybe? Oh, clarithromycin, okay. You know what? I learned something new tonight. I actually did not know that. That's very interesting. So I will say, for the classic board questions that you guys will soon encounter when you're in medical school preparing for your exams, the cliche scenario for rhabdo is when somebody, typically, like a young male, female athlete, is working really, really hard. And they work so hard that their muscle becomes damaged to the point that it breaks down and it releases its intracellular contents into the blood. And as you guys can see from the picture here, your kidneys don't like that. It releases electrolytes like potassium, and it also releases a substance called myoglobin, and that causes the patient's urine to become discolored. So that's what we're looking at in the picture here. So obviously a patient with rhabdo could have pretty severe muscle pain. And rhabdo isn't limited to athletes. It can happen from trauma as well, which is why we have it on our differential here. So do you guys have any questions at all about our differential diagnosis? Would we get blood work for a DVT? Yes, that's a great question. We absolutely would get blood work for a DVT. Yep, blood work, and also we would get some imaging too. We would probably order an ultrasound. Ultrasound is a very non-invasive way to get an excellent picture of the vasculature in the leg using sound waves to see if there's a blood clot. Good. Could it be a combination of more than one of these? In reality, the answer is yes. For the purposes of our meeting tonight, it's just going to be one of them. And for the purposes of your board exams, when you guys are studying for the boards, it'll just be one. Otherwise, it would be kind of unfair. But in real life, absolutely. Good. Okay, here we have our assessment, aka differential diagnosis, which we just talked about, and our plan. So to treat this patient, we need to take a picture of her leg to visualize her lower leg muscles and its surrounding tissues. Okay, any idea about which kind of imaging would be best for this patient? Thinking about what we want to look at specifically. Ultrasound. Excellent thought. MRI or CT? CT. Yes. Yep, CT. Angiogram, yes, exactly. We want to look at a CT angio or CT angiogram. And the reason why is because that gives us an excellent picture of the vasculature in the leg to see how is blood flowing. Is there a clot? Is there so much compression that there's no blood getting through? And we can see that with contrast, which is, injected into the patient's bloodstream and gives us an excellent picture of the vasculature within the lower extremity. Very good. All right, so we want to measure compartment pressure with a manometer and calculate delta pressure. Okay, this is a lot. Does anybody know what a manometer is? Feel free to Google. No thoughts, that's okay. It's kind of a hard question. I definitely didn't know it. So a manometer is a device that you use. It's kind of like a long needle that you use to measure the compartment pressure of, for example, the leg. And that's, as you guys could probably imagine, that's a key way to figure out what the heck is going on with this patient. So measuring the compartment pressure with a manometer is the best initial and confirmatory test to see, does this patient have compartment syndrome? And via that compartment pressure that the manometer will tell us, we can calculate the delta pressure. Does anybody know what the delta pressure is? Diastolic minus compartment pressure. Yeah, exactly. Very good. Yes. Does anybody know what a normal delta pressure is? 30 to 40. Good. Any other thoughts? 30. So yes, I agree with you. Typically around 30 or less is what we would consider to be a normal compartment pressure within a muscle. So obviously if it's different in our patient, that could confirm our diagnosis. All right, number 2 is consult surgery to have them assess the patient and determine if emergent surgical treatment via a fasciotomy is necessary. So, oh, I see a question in the chat. Would a manometer reading be considered invasive? That's a good question. I feel like this is a little bit of a subjective, my response might be a bit subjective. I would say overall no, comparatively to surgery, for example. But it's a little more invasive than, just collecting somebody's blood because you're putting, a structure into a patient's muscle. So yes and no. I know that's not the best answer, but that's what I would say, kind of yes and no. Okay, so surgical treatment with the fasciotomy, absolutely. So if you guys think back to the terrifying picture that I just saw you and be excited there are more to come, that is what a fasciotomy is. So acute compartment syndrome is a surgical emergency. That is something that needs to be addressed by surgery immediately. And there are things that you as the emergency physician can do in the meantime, collecting important data, with labs. Like you guys can see from this slide, we want to get labs to check electrolyte function. We want to look at creatine kinase, which is the product that's often present in muscle breakdown. That can tell us a lot. We want to look at their kidney function. We want to try to help with swelling itself by applying ice or cool packs and things like that. But really one of the most important and first things besides getting that compartment pressure reading that you need to do is consult surgery. Put in a call, tell them what's going on. You're going to present the patient to them and they're going to tell you essentially what they think they need to do, and they'll most likely come down and see the patient for themselves. But in order to save this patient's leg, if they do indeed have compartment syndrome, they have to do a fasciotomy, which is essentially cutting that very inflexible connective tissue that surrounds each muscle compartment in order to relieve that pressure to allow the body and muscle to get that blood it needs to the nerves, to the muscle, etc. All right, and then we have also imaging, which is important to get that CT angio or Doppler. Yes, somebody else in the chat earlier said ultrasound. So yes, very good. We want to do probably both in order to rule out a DVT. So very good. Okay, diving into the pathology. So we've talked a lot about what compartment syndrome is, but it can be kind of confusing, kind of overwhelming. So let's talk about it again. So acute compartment syndrome occurs typically due to either a trauma, leg getting compressed or squished in some kind of way from a falling branch like our patient, from a car accident, or it could happen in other cases such as a cast being put on a broken bone. If the cast is too tight, that could lead to swelling. That could lead to swelling to the point where the body kind of gets stuck and it has nowhere to go, and then you develop full-blown compartment syndrome. It can happen when you get an eschar. Does anybody know what an eschar is? That's okay. No worries at all. I'm going to tell you, an eschar is a scab, and you can develop, yes, so I see dead tissue in the chat. Yeah, so an eschar is a scab, and that is So when you can develop compartment syndrome from an eschar would be, for example, when a patient gets a burn, a circumferential burn, meaning that the burn wraps around the entirety of the lower leg, for example. And as you guys probably know, when you get a scab, at first it's kind of squishy, but over time it dries. And when it dries, it shrinks. And when it shrinks, it can put compression on the skin, on the muscle, etc. And that can lead to compartment syndrome too. So that is an overview of compartment syndrome, and the consequences of which we talked about would be compression of the vasculature so that the muscle isn't getting the oxygen, the nutrients it needs to survive, also leading to compression of important structures like the nerves, which you need for sensation, which you need for movement, etc. Any questions at all about that? Okay. And then I'm sure you guys realize this, but picture of a patient with compartment syndrome. So fasciotomy was completed for this patient, probably in the ICU to help relieve that swelling. And then there's a diagram of a fasciotomy itself. Okay, diagnosis and evaluation. Here's the manometer. It's kind of scary looking, but really not too bad. Just measuring that very important compartment pressure so we can calculate the delta pressure to determine whether or not our patient actually has compartment syndrome. So when to be suspicious? Pain out of proportion to the exam, meaning the patient, is screaming in pain with just a little bit of light touch, for example, or when you're going through range of motion, passive range of motion, meaning that you as the physician or medical student are moving that patient's ankle or leg yourself and they're having terrible pain, more than you would expect. That's pain out of proportion to the exam. Tight looking skin, and then difficulties with range of motion or sensation. So like we talked about before, need that manometer, got to calculate that compartment pressure so we can see if the patient's delta pressure is greater than 30. That's when we would start to be worried about compartment pressure. And then here's just another picture of anatomy. I like this one because it's of a cadaver, which you guys will have experience with in terms of dissection, learning about anatomy your first year of medical school. It's a very exciting, incredible privilege to work with cadavers. It's a wonderful gift that the donors give us to learn. So something to look forward to. But anyway, I like this picture because it tells us a lot about the real anatomy versus a cartoon. And you can see the structures for yourself. You can see that anterior compartment, the tibia, which is the largest bone in your lower leg. Anybody have any questions about this picture, this diagram? Okay. Treatment, okay. Surgical emergency, most important. What's the most important thing that we can do for a patient when we suspect compartment syndrome, besides getting that manometer read? Anybody have any thoughts? Consult surgery, exactly, very good, exactly. Yep, so in the emergency department, as cool as I think it is, there are some things we just can't do, and one of them is a fasciotomy. So gotta get surgery on board, have them take a look at the patient, and in the case of our patient, do that fasciotomy to save her leg. And what you guys are looking at is actually a forearm. And the technique that they used for this particular fasciotomy is the shoelace technique. And what's cool about this is they cut the fascia, allowing that muscle to have the opportunity to swell and expand as much as it needs to. And then over time, they tighten those shoelaces. And then we'll eventually suture or close up that skin when the swelling has been relieved. So kind of a cool picture. And then we have some possible complications. Obviously, if you're not able to, do the fasciotomy in time, the patient's muscle and tissue can die. And that's what necrosis means. Soft tissue necrosis is the tissue essentially dies. It's irreversibly damaged. Muscle contractures. Does anybody know what contracture means? Permanently in contraction. Yeah, that's exactly what it means. Yep. So sometime when you guys are doing your clinical rotations and are in the hospital, you'll see that some patients, for a variety of reasons, not just compartment syndrome, have these permanent contractures, whether, you know, their arm is permanently contracted at the elbow, or it could happen to their leg, or even fingers sometimes. But that is a complication of compartment syndrome as well. And then rhabdomyolysis, which you guys are already familiar with, which is damage to the muscle tissue when either you're a young athlete and you're working out super hard to the point where the muscle actually breaks down, releasing intracellular contents into the blood, like electrolytes such as potassium, and also myoglobin, which your muscle needs, obviously, for getting all the oxygen and nutrients that it needs. So your kidneys don't like that. And a symptom of it could be having Coca-Cola colored urine or dark urine. So that's another possible complication of compartment syndrome. And that's it. Can't believe it. Does anybody have any questions about the presentation, the information presented, about medical school, anything at all? Well, while you guys are thinking of your questions, I just want to thank you again for joining us tonight. It's such a pleasure to be able to talk with you guys about a really cool pathology that I'm excited about. Hopefully you guys feel excited about medicine too and your own journey. This is such a great way to dip your toes in and start getting familiar with the material that you'll need to know for the rest of your life. All right, Rachel has a question. Whenever there is pain and numbness, is it most likely compression of the nerves in any structure? That's a really good question. So not necessarily. That definitely can happen, like in compartment syndrome, for example, or I don't know if you guys have ever bumped your funny bone, which is actually your ulnar nerve in your elbow, and you get that terrible like pins and needles sensation. So you can definitely get it from trauma or compression, but you can also get it from conditions like diabetes, which lead to issues with your nerves and things like that. So it's not necessarily limited to compression, but that's an excellent question. So the bones are unaffected in compartment syndrome. Yes. Yep. Certainly, you know, for this particular patient, we would want to rule out a fracture of the leg. A great way to do that is with an X-ray. But for acute compartment syndrome, it's really swelling of the muscle itself. Thanks again, you guys. Tonight was really fun. I hope you enjoyed yourselves. I hope you feel excited about medicine and your own journey to going to medical school. We're all very grateful to have you here tonight. Thank you so much.